Can I start?
Once we will go live and have a short intro after that.
All right, sure.
We are live now, sir.
Okay. Hello everyone. Welcome to today's session, Basics of Laparoscopy. The White Army is privileged to have Dr. K. Lakshman sir, a renowned consultant laparoscopic surgeon from Bengaluru, as our mentor today. We are honored to have you with us, sir. Welcome to you.
Thank you.
I welcome all the participants to the session. Without further ado, we shall begin the session. Over to you, sir.
Yeah, thank you very much. Good evening to all of you. Thank you for giving me this opportunity. I always find it interesting and exciting to have discussions with youngsters. Okay, makes me feel less old than I really am. Huh? Okay, I think all of you know that the attention span of the human brain is 20 minutes, and Kishan has put up this program for 90 minutes. And I don't think you guys will want anybody to go on for 90 minutes. So there are two things that I propose to do with your permission.
Exceptions are always there, sir. Exceptions are not examples.
Right.
One of them is Lakshman sir's classes. And they're more than a class, monotonous classes. It's a more of an interactive session and very interesting one, sir. So there's no time limit for them. And we are really interested to learn the basics from the expert. So we are here to learn, sir. So time is not an issue, sir. Thank you.
But what I'll do, permit me to do this, we will stop at around one hour and we will go on and have another session. Because I do believe that the retention rate is much better if the session is not very long. And of course, I've made it interactive. You know, instead of giving a didactic lecture, we will have a discussion, and I'm sure very, very bright young souls will know a lot of it about it. And more than my teaching you something, let us have a discussion where both of us learn as we go along and discover knowledge, because knowledge is something which is ever eternal and that we always keep learning as we go along. Okay, so I need first of all 2 or 3 volunteers who will take the questions primarily. So can I have the volunteers, please?
Yeah.
Kishan or Pallavi can name 2 or 3 people. Tell me the names.
Mr. Javed, I think any surgery residents here, please raise your hands. Surgery residents can please volunteer. Okay, even others, Rishabh is there, a very active member of White Army. Okay. And others can also please be volunteer yourself. Okay, sir is very sweet. He will teach nicely. Who are volunteers, he will have a special advantage over others. Please come up to volunteer. I think some surgery residents are there here. I can see.
So,
Tapan, please unmute Javed and Rishabh. We'll see.
Okay, let's start with Javed and Rishabh. And then as we go along, some people may join and some people may leave. I would also like
joining YouTube.
Okay, and I would like Kishan, and if Nishant has logged in, and anybody else in fact, even residents chipping in with information that they feel everybody should know, which I may not mention. All right. The operative word here is the basics. The reason I'm saying that is that until 5 years ago, you may not believe this, until 5 years ago, many teachers in the country felt that laparoscopy is a post-MS subject. Post-MS, mind you, they felt that the MS people must know the basics, and that the MCH guys who are doing GI surgery or whatever else, they should be really learning laparoscopy. And I'm very, very glad to see that White Army, which addresses undergraduates as well, I learn undergraduates primarily, has felt that laparoscopy should be a topic. And I completely agree with it, because today there is no surgery without laparoscopy. And I'm very, very glad that this is being done. But I will not be going into great depths of laparoscopy and the techniques and the technology. I will be introducing you to the basics of what we need to know. And as I said, that will be in the form of a group discussion. Now, just to give you a background, general surgery was in a crisis in the late 80s. Even now the crisis continues, but to a lesser extent, because most of the specialty branches developed in the 80s. Okay, for example, in 82, when I got my fellowship, my FRCS, general surgery was a very vibrant, very widely practiced kind of surgery. Oncology surgery was there. GI had just started as a specialty by itself. But then as we went along, these specialties sort of took over large chunks of the material that general surgeons were dealing with. So if you look at the fate of general surgeons in the 80s and early 90s, there was a crisis of identity. They didn't know what they were, they didn't know what they had to do. And that's when laparoscopy came as a breath of fresh air, because that really took the world by storm. It had several advantages. We'll talk about it in a minute. And so this science called the keyhole or minimally invasive surgery just really took off and gave a fresh lease of life to general surgeons. And so they took to it like fish to water, as they say, and the specialty grew leaps and bounds in the 90s and the early 2000s. And now it has matured over 20 years of practice, 20, 30 years of practice. It has matured, and a lot of things are done laparoscopically that we could not even have imagined when we did our post-graduation. Almost all of or not almost, everything of laparoscopy came in after we did our post-graduation. And I've been lucky enough to grow with the specialty. And so I got a very nice, gallery view of how the specialty has developed. And that's always been an exciting process. Now, why did it take the world by storm? Nothing else had done it in my imagination. Perhaps antibiotics did in the 30s. Endoscopy did in the 60s, perhaps. But laparoscopy was the real advance in surgery in the 90s. Javed, why do you think that it took off so well? Are you there? Can you hear me? Rishabh?
So because it was less
Okay.
traumatic.
All right. All right.
And it was cosmetically better.
Okay. Correct. Anything else? Rishabh, do you want to add to that?
This is Rishabh speaking, sir.
All right. Javed is not there. Pallavi, are you there? Can you add?
Sir, less amount of hospital stay, time
Yes.
duration. Hospital
Yes.
stay increase.
Yes. Shorter stay in hospital.
Um,
All right. Anything else? All right. If you put something, the advantages of anything or disadvantages of anything, the most effective and perhaps the most common thing has to be put first, and the least important must be put in the end. And in that, if you look at that, cosmesis, in my view, comes last. Okay, cosmesis is important. I'm not saying no, but there are a lot more important things that happen with laparoscopy, which was not available for open surgery. I'm talking about reduced metabolic stress. Rishabh, can you come in again? Tell me what do you mean by this?
So there would be less bleeding. So the body has to not, there won't be increase in the basal metabolic rate to compensate for the blood loss.
You think it's only the bleeding that matters? If you had
Even
an injury without bleeding, would it or would it not cause stress?
it would, sir.
Any infections or anything, sir?
Yeah, even without infection, please understand that surgery is an injury. Okay, hopefully it's a controlled injury. If you are a good surgeon, you will be inducing a controlled injury. That is a very important point you must remember as surgeons. Okay, so that injury, any injury, be it a road traffic accident, which is an uncontrolled injury, be it an assault, even more uncontrolled perhaps than a road traffic accident, or a surgeon's knife, which is a very controlled injury, nevertheless is an injury. When that injury occurs, a set of metabolic changes occur because of a neurohumoral response. The hypothalamus responds to the injury. It stimulates the pituitary through the neurohumoral axis. a set of hormones are released. All right? Are you familiar with the steps of a metabolic stress, Rishabh?
Not exactly.
Pallavi?
No, sir.
I'm glad I asked this question because all of you must understand the basics of this. The sum total of this metabolic stress, you must have heard of the fight or flight response that all animals go through when there is a danger of any nature. So injury is a danger. So you have a set of hormones that are released. It's a set of catabolic and metabolic hormones, which in the end result in two things. One, increased metabolic rate. It can be 200 to 300% increase depending on the amount of injury, and nitrogen loss by mobilization of the nitrogen from the muscles. So the lean muscle mass is reduced. The proteins are lost. You need the protein for the metabolic rate and for building tissues. So when injury occurs, a set of hormones are released, which result in increased metabolic rate and increased protein loss. This is what impedes, if you do not have good nutrition to cover this increased losses, this is what impedes healing. This is what allows infection to come in and cause more further damage. As Pallavi rightly said, infection also can increase the metabolic rate. So that is an added insult to the injury. I won't go into the which hormones are released, which are anabolic or which are catabolic. That's a topic by itself. But remember that the main anabolic hormone is insulin, and the main catabolic hormone is glucocorticoids. ADH, glucocorticoids, mineralocorticoids, and a lot of other hormones are released, and they result in the increased metabolic rate and increased loss of protein. Now, this occurs not because of the gastrectomy that you do or a cholecystectomy that you do. It's because of the main wound that you have. When you do a laparotomy, when you cut open the tummy, that's a main wound. And that is the main source. And so when you avoid that wound in a laparoscopy, the metabolic stress on the body is much, much less. Right? That is what is a big advantage of laparoscopy. Less pain. There is no wound. Lot of dermatomes are not cut. Muscles are not cut. And so the nociceptive stimulus is lost in laparoscopy. It's reduced. I can't say lost, it's reduced. And you have very little pain. And pain, again, worsens metabolic stress. Pain itself is responsible for the release of hormones along with the injury. So less pain, less metabolic stress. Less pain, quicker recovery. All right. And less pain, less use of particularly narcotic analgesics, less ileus. One of the things that we always saw in a laparotomy is that it takes 3-4 days for the small bowel to recover. You would keep the patient nil oral for a long time until the bowel sounds came back. Those things are all out of the window now. We now have a concept of ERAS, which is early recovery after surgery. And the whole concept has been turned upside down with the arrival of laparoscopy. There is very little use of analgesics, particularly we hardly ever use narcotic analgesics. The ileus is less. You start early nutrition, which improves the healing. And so there is early recovery. And yes, better cosmesis. Undoubtedly, you don't have a large scar. It is something that most patients welcome. All patients welcome, in fact, I think. But as I said, I would put this last on the list. So remember, the main thing with laparoscopy is reduced metabolic stress, less pain, early recovery, better cosmesis. There are certain disadvantages which I'll be talking about as we go along. So this is a short introduction, but I would like you guys to come out with, say, what is the origin of this word laparoscopy? Rishabh.
So introducing a scope into the abdomen.
Mm-hmm. That's true. That's true. But what do you think this word came from? Which language? What was the basic,
Latins.
Latin. What was the closely related ancient language? The other one?
Greek.
All right. So it's more from the Greek rather than the Latin one. Lapara in Greek means the flank actually, or the side, not necessarily the abdomen. Scopio is looking inside. Okay, so looking into the abdomen is basically this. The origin of the word is from the Greek word, and basically what you said was right. It's a process where you make little holes and introduce a telescope and look into the abdomen without having to cut open to see the inside. Okay. Now, I would not expect you to talk about the history or know about the history on landmarks. So I will go through this because it's nice to know about the time scale at which all this was done. Please remember, I said that laparoscopy took off in the 90s. Okay, 1990 onwards, it became very popular. But a lot of basic work had gone before that. Okay, Kelling was the man. Look at the curiosity of these people. He put a little telescope. They used to have cystoscope actually. They had a little scope. Imagine there was no light source. The light was coming from the outside, and God only knows what they could see. These were very short things. They would in fact have a lamp burning outside. They put the light to shine the light inside. I'm sure they saw very little, but they had a curiosity, and Kelling put a little scope into a dog's tummy in 1901, and Jacobius is credited with doing the same thing in a human in 1910. This gentleman, Janos Veres is called, from Hungary, is the inventor of the Veres needle. When we talk about the instruments, I'll tell you a little more about the Veres needle. It's a very essential tool for the laparoscopist. It was basically used to drain the chest of fluid. If you had an empyema or a hydrothorax, he used that, and the idea was that it should not damage the underlying lung. So he had a little contraption, call it the Veres needle, which was basically a double needle with an inner blunt needle which would stick out of the sharp needle, and that blunt needle would move up and down because it was spring loaded, and the sharp thing would come out, or rather better to say the blunt thing would go in if it felt a resistance. And so the sharp thing would then go through the tissues or the muscles, and when it came on to a soft organ like the lung in the chest or the bowel in the abdomen, the spring-loaded inner blunt needle would come out and would not damage the internal organ. That was his invention, gentleman from Hungary. And obviously, initially there were no telescopes. You couldn't put anything in, so they would just put a tube down, shine the light from outside, and look at what they could in the abdomen. But then the act became a lot better with the discovery of the rod lens system. We'll learn more about it as we go along. Hopkins from the UK is credited with it, and this gentleman of Indian origin but working in the physics laboratory in California in the US has been attributed with an equal measure, even though his name, Kapani, his name is not mentioned as commonly as Hopkins. I'm told he had an extremely important role to play in the development of the rod lens system, and we can all be truly proud of that. Now, this gentleman is a gynecologist, Kurt Sam from Germany, and he was really a pioneer. Believe me, even though now general surgeons and laparoscopists do a lot more than many gynecologists, the origin of operative laparoscopy came from this gentleman. He was a great inventor, a great enthusiast. He could do wonders, and he was doing a lot of pelvic work. He even did an appendicectomy, of course, but didn't venture into the upper abdomen or the bowel surgery. But he was basically a gynecologist who developed a lot of instruments for operative laparoscopy. And among the general surgeons, Philippe Mouret in Lyon, France, is credited with the first laparoscopic cholecystectomy in 1989. And it took the world by storm. What is very interesting is that generally for a new technology to take hold in the world, it takes about a decade. If you had the first invention of, say, a CT scanner somewhere or an MRI, For it to reach the rest of the world for common use, it takes about 10 years minimum. But with laparoscopy, it happened within 1 to 2 years. That's a very, very quick development. It spread like wildfire. And the first lab collie in India was done in 1990 by Professor Tempton Udwadia. And, we did our first lab collie in Bangalore in January 1992. So it really spread very, very quickly. But Philip Moray has the distinction of doing the first lab collie. I will be shifting between instruments and some of the techniques and technology so that it makes it a little more interesting. Now, we all know that the abdomen is a potential space. There is no space in a normal abdomen, but you need space to work in. When you cut open the abdomen, you put your hand in, pull things apart, you create space, and then go and do whatever you have to do, remove the appendix or the gallbladder or the stomach or whatever. But you're not having your hand inside the abdomen. Everything is outside. It's a box, but you need space. And so the first challenge in laparoscopy is to create space. Now, Rishabh, can you come in and tell us what options we can have to create space?
So we put in CO2.
Okay. Can you do it without putting the CO2 in?
Yes, sir, but it will be difficult.
What can you do to do it without putting CO2 in? Pallavi?
Not sure, sir.
Not sure. Is Javed here? Has he joined in or anybody else wants to come in?
Tapan, you are there, no?
Tapan, all right, Tapan.
Sir, is
PG.
retractions are possible, sir, in case of
Retraction? Yeah, you're right. But what would you call it? If you retract something, what would you call it?
Sorry, sir, I couldn't hear the question.
If you call it retraction, what would you call it? How would you retract? You can't put your hand in, so what would you do?
Sir, by the use of the instrument, we can pull the organs away from the field of the space.
Are you pulling the organs away? What are you pulling away? When you put gas into the abdomen, for example, yes, are you pulling the organs away from wherever?
No, sir. Peritoneum, sir. Will.
What are you pulling actually? How are you creating space? The organs remain where they are, right?
Yes, sir.
Yeah, but what are you actually pulling away?
Sir, peritoneum will the potential space.
Not the peritoneum. It is actually the abdominal wall.
Yes. Yes, sir.
Okay, you're creating a space. You expand the abdominal wall, so there is some gap and some space between the anterior abdominal wall and the organs inside. Yes. Instead of putting gas and insufflating, that's called insufflation. You can lift the abdominal wall up. Yes. Right? So you put a little rod inside, make a little hole. Okay. Put a little plate or a little rod through the umbilicus perhaps, and put it against the abdominal wall and have a lift. Have a mechanical lift and lift the abdominal wall up. That's possible, all right? But it is not popular. So these are the contraptions that have been used to lift it. This is actually an Indian modification of the contraption. You can see that these are the two plates. Can you see the plates here? You're seeing my pointer?
Yes, sir.
Okay, so there are two little blades, small ones. They can stick together as one unit, then they can be spread apart. So you stick it into the abdomen, and this goes into the abdominal cavity through a hole in the umbilicus, and it sits against the abdominal wall, and this is a lift. Can you see a ratchet here? The whole thing is either coming onto the floor, or it can be fixed to the side of here it is shown fixed to the side of the operating table. So when you do that and when you lift it, the whole abdominal wall gets lifted up. All right. And it has certain advantages. What are those advantages? There is no intra-abdominal hypertension. Okay. When you put gas and raise the pressure, if you don't have enough space, you put more and more pressure in, and that has its effects, and we'll discuss that as we go along. Here, there is no such thing. You're just lifting the abdominal wall up. There is no abdominal hypertension. The gas, whatever you put in, we'll discuss that also as we go along, has certain adverse effects, which this doesn't have. And very importantly, you can use the conventional instruments. Okay, you can make little holes again, use the same artery forceps that you use, take a longer artery forceps perhaps, and then use the same thing that you would do in an open operation, almost. It's not totally true, but nearly so. But there is not enough space. When you lift up you don't get a cupola, you don't get a nice dome, you get regional lifting and regional collapsing, and so you don't get the kind of space that you really need. And setting the whole thing up and pulling it up and the whole palabra is very cumbersome, and if you keep overdoing it, they'll have tremendous pain. Remember, we said that one of the advantages of laparoscopy is less pain, but if you put this in and pull the muscles in all different directions and keep lifting up for a long time, then it can cause more pain. So this Laparolift, or the lift option for a laparoscopic creation of space, while it's available, has never become popular. All right. So most of us, all of us in fact, now use insufflation. And of course, we need to understand when you do something, what are its advantages and what are its disadvantages. So Tapan, over to you. Rishabh mentioned carbon dioxide as a gas. That is true, that's the commonest gas, but are there other gases that are available? If so, what are the advantages and disadvantages? And what do you think are the ideal features of a gas that you would use to create space?
Sir, ideally, the gas should be inert, and it should not have any property to burn in case of cautery.
Very good.
It should be diffusible.
Yes.
Is there any gas? If any gas remains, and and it should be easily available, low cost to manufacture.
Excellent.
And as well as
I think you covered nearly all of it. Okay, so carbon dioxide is one that was mentioned. Anything else that you can think of?
Sir, helium probably.
Correct.
And sir, not sure, sir. Other examples.
Not sure. All right. Now let us look at it. Yeah, that's good. You did well. These are your options. All right.
Okay, sir.
Okay.
Yes,
helium is also there, I must say, but argon is preferred to helium in this. Okay. Air is one of them. What are the advantages and disadvantages of air? You mentioned a few advantages, and they're all correct. Yeah.
So air is easily available, but
yes,
again, because it has oxygen, it has a chance of burning.
Inflammable. Yes. So you can't use cautery or any energy source. You'll have an explosion. Yes.
And so
it also has nitrogen. So what would happen?
Oh yes, sir. It can cause bends like symptoms.
Gas embolism.
Gas
embolism.
Yes.
So when you open up a small blood vessel, if you have air under pressure in the abdominal cavity, because nitrogen doesn't dissolve in blood as does oxygen or carbon dioxide, you will have bubbles, and the bubbles can give you air embolism. So air, people who are doing tubectomies, for example, would just use air, and it's now out of the question as far as any kind of operative laparoscopy is concerned. It should not be done. Carbon dioxide is the commonest, easily available, relatively cheap, okay, not inflammable, and has some metabolic effects. It can cause hypercarbia. What would hypercarbia do to the patient?
Acidosis.
Yes. More than acidosis on the table. If the patient has hypercarbia, what happens that adversely affects the surgeon?
Erratic respiration. Respiratory rate will be imbalanced.
Yeah, but the anesthetist has a control on the respiration.
So high BP, sir.
Correct. High BP. Directly responsible because it causes more operative bleeding. Even small blood vessels, which would otherwise not bleed, when the BP is high, can cause hypertension. Can cause excessive bleeding. And post-operatively, the patient will have a lot of headache and other systemic symptoms, which would be unacceptable. It will not be comfortable for them. Nitrous oxide is an option. It dissolves well. It's not inflammable, doesn't explode. But what are its disadvantages? Easily available relatively, but more expensive than carbon dioxide. One of the things that happens is that it somehow diffuses into the gut lumen when it is put into the abdominal cavity. And when that happens, the intestines bloat with the nitrous oxide, which has diffused into the lumen. And so you have a limited space, and if you have a bloated gut, that limited space will be further limited. So nitrous oxide is not favored. Argon is a very ideal gas actually, but very expensive, not easily available, so it's not used. So to summarize,
we can use helium also.
Yes, you can. Again, it is expensive and not easily available. Okay, but it's not at all on the list of on the list that are commonly done. Argon is, I think, one of the things that was tried, and even now, even this is not used. So across the world now, carbon dioxide is the preferred gas. So to summarize, what you look at is availability, dissolution, explosion risk, and cost. And the others include metabolic risks, and that is not, that we'll discuss in a minute. Particularly with carbon dioxide, in patients who have respiratory disease. In people with normal lungs, it's not a consideration. But in patients who have ventilation perfusion mismatch, or who have COPD, or any kind of lung disease which impairs gas diffusion, even carbon dioxide can be a tricky option. All right, so we come to the insufflation problems. Let us focus on carbon dioxide, but that's because that's the gas of choice. What are the problems? We already mentioned one about hypercarbia, but in terms of principles, what do you think the problems can be? What are the basic ways in which gas insufflation can give you trouble?
So irritate the diaphragm.
Irritate the diaphragm. All right.
Abdominal,
okay.
Abdominal hypertension can occur.
All right. You get an increased pressure in the abdomen, and what effects would that have?
So pressure on the veins, the IVs.
Yes. Very good. So that reduces the venous return. So because of a very low preload, the patient can become hypotensive. Yes, correct. Anything more important? We talked about irritation of the diaphragm. What about the mechanical effect on the diaphragm when the abdominal pressure increases?
The vital capacity will
reduce. It lifts up both lobes of the diaphragm and pushes it back into the chest when the intra-abdominal pressure is high. It has effects on the lung as well as the heart, right? When the heart's orientation is changed, its axis is changed, it will have some effects. When the lungs are lifted up from below, that will have some effects. These are mechanical effects, right? Can there be anything else? There can be metabolic effects of the drug itself, all right? The carbon dioxide circulating in the blood has its effects. So there can be mechanical and metabolic effects. So we talked to you already, I gave you a hint that you can have, apart from, as part of the mechanical and the metabolic effects, you can have both pulmonary and cardiac consequences. So can you guess a few, Rishabh?
Yes, sir.
Go on. Have a go. No problem.
I didn't get your question.
When you lift the abdomen up with carbon dioxide, we made the point that you can have mechanical and metabolic effects, and the effects can be both on the heart and the lungs.
Yes.
So what are these possibilities? What are the things that can happen?
So reduced venous return and
Yes.
reduced vital capacity.
Okay. One on the lung, one on the heart you mentioned. Yeah, anything else? Anybody else? Pallavi? Tapan? Okay, let's look at this. I told you, increased intra-abdominal pressure, okay? Increased pressure and the effect of carbon dioxide on cardiac, CVS, cardiovascular system. I have one slide for cardiovascular system and one slide for the pulmonary system. Look at the number of effects it can have. There will be an increased arterial pressure because of carbon dioxide. Systemic vascular resistance is reduced because of carbon dioxide, but significantly increased because of the intra-abdominal pressure. CVP can be variable. You know, if the pressure is very high, the CVP will be low because of venous return. If the pressure is moderate, the CVP can go up because of the hyperdynamic circulation. Carbon dioxide definitely increases CVP. Cardiac output will be less. It will be increased because of the stimulatory action of the carbon dioxide on the heart. Heart rate will be high in both. Stroke volume can be variable because of intra-abdominal pressure, but is always high because of the hyperdynamic circulation induced by carbon dioxide. So all these effects occur because of A, increased intra-abdominal pressure, and B, carbon dioxide on the cardiovascular system. Now, you mentioned one, that vital capacity is reduced, which is true, but you can see the number of arrows here, 1, 2, 3, 4, 5 effects on the lung. Any further guesses?
Respiratory rate will increase.
Okay.
SpO2.
Okay. The important thing there is the compliance. Okay. Inspiratory pressure increases, compliance is less, vital capacity is decreased, functional residual capacity is decreased, and intrathoracic pressure, of course, goes up. Okay. The sum total of all these is that the patient will have reduced oxygenation, he will have increased carbon dioxide retention, and 3, may either become hypertensive or hypotensive. Okay. But having said that, there is so much of laparoscopy going on safely in the world today that if somebody has a relatively normal cardiovascular system and a relatively normal pulmonary system, the pneumoperitoneum is a very safe proposition. Any number of studies have shown that even in people with compromised cardiovascular and respiratory systems, the safety of laparoscopy is well established. It is no less safe than open surgery, provided, this is the caveat, this is the thing that everybody must know, provided that their cardiovascular and respiratory systems are optimized preoperatively. That means cardiac failure is attended to, volume replaced in somebody who is dehydrated, somebody who is overloaded is given diuretics and volume normalized. They're given bronchodilators to reduce the bronchospasm that may be there. They stop smoking for 2 to 3 weeks to make sure that that is not impeding the pulmonary function. So when the person is optimized with good monitoring, the minimum monitoring is an invasive blood pressure monitoring, not non-invasive, just not a cuff, perhaps have an arterial line and measure the blood pressure, capnometer, and inspiratory airway pressure. Modern anesthetic machines give you the inspiratory pressure. So you measure that and keep it within normal limits, keep the carbon dioxide within normal limits, get the pressure monitored properly by an invasive monitoring and keep that under normal. So if you have these 3 facilities in the OT, and if you optimize the patient, then laparoscopy, even in people with some cardiovascular or respiratory compromise, is as safe as in open surgery. All right. So let me take a little break here and invite questions from you, from the audience. Somebody, if it is being streamed on YouTube or Facebook, somebody, Kishan or somebody, can please monitor the chat box and pose questions. And I would like the seniors, whoever is here, or even the juniors, no discrimination, to make your comments about whatever I have said so far and ask questions if any.
Tapan, if any questions are in the YouTube, you can stream it here, okay? You
Sir,
can,
no
push it here.
questions sir, in YouTube.
Okay,
Sir.
no, if anyone asks any questions in YouTube,
Yes,
you
sir.
can
Yes.
ask.
You have any comments to make, Kishan?
No, sir. Learning a lot, sir.
Learning a lot. Is
Nishant is there.
Nishant,
Nishant is
Nishant
there.
logged in. Nishant, you have any comments, questions? All right. If there are no questions, let's proceed. Now, the abdominal space you have created, but it is dark inside. Unless you have good light, you cannot see. And one of the problems of throwing light from outside, like you do in open surgery, we always struggle, in the nooks and corners, even in open surgery. We keep troubling the OT staff and the anesthetist to keep on adjusting the light. So unless you have good light, you cannot see. So if you have to throw light inside the abdomen, okay, what are the challenges that you might have? Rishabh.
So you have to visualize the structures on the screen, so the light source be good enough. And
Yes, it must be a very strong light in terms of luminosity, lumens. It must be a high luminosity light. That's correct. And if you have a high luminosity light, what are its problems?
it can cause burning effects.
Yes, it will be very, very hot. Okay, it will be very hot. And so you need to somehow make sure that the temperature, you need a bright light inside, but when the light goes inside, there's no heat, associated heat. What is that process called where extreme heat gives you light?
Radiation.
No. What is your ordinary light bulb called? What was it called earlier? It was called
Incandescent light.
Incandescent light. Good. So incandescence. There is what's called an incandescence temperature. A temperature at which something which is very hot throws up light. So that is a very hot temperature. And we cannot afford to have that anywhere near the abdomen, because it will burn tissues. So you need to have a cold light source. All right. So how do you define, or what do you mean by a cold light source? Pallavi.
Without any increased heat, light.
It's very true. It's very true. Well below the incandescent temperature, you must have something that gives you light. Okay, that's one of the definitions. Light emitted by any body whose temperature is below that of incandescence. That's one of the definitions. The other one is you have visible light from whatever source, unaccompanied by appreciable amounts of infrared wavelength, which means there is very little heating effect. All right. The source itself may be very hot. Nobody questions that. But at the time it comes into the abdomen and shines up the inside of the abdomen, you should not have any heat. So the first requirement of lighting up the inside is a cold light source. Okay. So what you have is a light bulb, whatever. We'll talk to you about what those bulbs are and what they are in one place. And then you have something to transmit the light from there into the abdomen. But a fundamental question arises: when it comes into the abdomen, is it really cold? That is something all of us have to address and understand. Okay, I don't expect you to answer this question. The answer is that it is not really cold. Why is it important for the surgeon to ask the question? That's a simple common sense question. Tapan, tell me, why is it that I should know as a surgeon that the light that I'm shining into the abdomen is not really cold as I expect it to be?
Sir, we'll be cautious to not burn the tissues there,
Yeah,
or
you
it can
don't
cause
touch your
adhesion.
telescope. The telescope lens system in the telescope is throwing the light into the abdomen, you're right. And so you don't actually touch the tissues inside with the telescope because you can burn them. That's what you should know. When do you think the surgeon would be tempted to touch some instrument or some surface inside with the
Sir,
telescope?
to look in the deeper structure or any recesses
No,
through
you're
which.
still in a space. When do you think, actually even now, many surgeons are tempted to, and they actually do touch surfaces with the telescope, which they should
if
not, but they do.
if there is some material on the scope to clear it.
Yes, when you want to clean the scope, okay? When some blood splashes, you have to take it out, clean it, and put it back in. That's a time-consuming and effort consuming process. Many people are lazy, including me. And so what we are tempted to just swipe it against something more than blood and tissue clouding your telescope. What is very common is water vapor. Okay, the cloud, the lens fogs with the water vapor in the abdominal cavity. And so you're tempted to wipe it against something. You should never do it. That's the message. If it is hazy or if there is some material on it that is obscuring your view, take it out, clean it, and put it back in. Because these are the documented temperatures that you have. Okay? So if you have the outlet of the source, the cold light source, which is sitting on your laparoscopy rack, it is all in degrees centigrade, 750. There's a cable that brings it on to the telescope. You attach the cable from the light source onto the telescope, and that cable has 250 degrees. I've actually seen cases when that cable with the light source on, it is not attached to the telescope but left free on the patient, and I've seen it burn the drapes, burn the cloth drapes. It's made a hole in it. All right, it is not very difficult. If you don't notice it, it will burn through 2 layers of cloth and it can burn the patient as well. So it's very, very important that you don't leave the cable with the light on lying on the patient, because the temperature there is 250 degrees. And even at the tip of the scope where the light is just transmitted, it can be as high as 100 degrees. Okay, and so the point is, a cold light source is definitely colder than what would happen if you had the source right at the abdomen, but it is not really cold. It has the potential to damage tissues. So do not touch anything with the telescope which is transmitting light. That is the take-home message. Now, I told you about the source. There are so many things that can throw bright light. So can you name some of the things that are commonly used? Pallavi?
Halogen bulbs.
Yes, correct. Anybody else to add?
LEDs.
LED, very good, very good. In fact, that's the latest. Okay, so there are some advantages and disadvantages of all of them. Halogen was in fact the most common and one of the first lights to come. The normal incandescent bulb that we have is never bright enough. So you need to have something much, much more bright than that. They have a low voltage and have a good average lifespan of 2000 hours. And it's not too bad at all. But there are advances. We then moved on to xenon. And it gives a better white quality light, and it mimics natural light more than halogen does. And so it actually has a longer life. It's also more expensive. Okay, but xenon is many systems even now have xenon, but the latest on the field is LED. Longer life, it's actually the best, and it has better saturation and contrast and better luminosity. So some of the most of the operating theater, I'm talking even about open operation. Most of the operating lights, the domes that you have on the operating table, and the cold light sources for laparoscopy and other minimally invasive operations, they're all now switching on to LED. Okay. Now, the light which is coming out of this box with either the halogen or the xenon or the LED bulb has to reach the telescope on the patient's body. when you're operating. So you have cables, okay? And the cables have to transmit that light without transmitting the heat, and have to not lose the luminosity in the process of transmission, okay? And to meet that, you need to have transmitting cables. What do you think are the cables used, and what should be its properties? Tapan.
Sir, if it is transmitting electrically, then it should have low resistance. Otherwise, heat will be produced.
There is no electricity involved. It's just luminosity. It's just light.
Okay, sir. Reflecting surfaces probably internally.
Yes. So you can use a mirror.
Yeah.
What would be
Yes,
the problem with
yes,
a
sir.
mirror? I want you guys to think, I mean, this is how all these things developed. And so I want you, or you can use a prism that also transmits light. What would be the problem with the prism?
There'll be
It will be
refraction.
probably it will be brittle and all. So
Yeah, it can break up the light, for example, and it cannot bend it very well. Okay. But you remember, you need to transmit over a length, that will be about 2 meters long, 6 feet long, coming from the laparoscopy trolley onto the patient. So you can have a rod lens. We talked about rod lens. We'll talk a little bit more about it later on. You can have a rod lens that can do it.
Yes.
But what would be the problem with a rod lens? Just straight, rigid rod.
Oh,
Okay.
okay. Then we cannot bend
flexible.
it. So
it's not flexible.
Yes.
It will break.
Yes.
And you have one straight rigid rod coming from somewhere to your. How can you actually make it? So you need this cable has to be flexible.
Yes.
And it should also not lose transmission capability of the light. So what should you have? How can you bend light? It means essentially you're bending light. How do you manage to bend light without losing its luminosity?
Refraction.
Sorry? We just said that reflection is not possible.
Refraction.
Refraction, yes, but something better than refraction. Refraction also doesn't bend it as flawlessly as this phenomenon. What happens when you have refraction with increasing angles of incidence?
Total internal reflection.
Thank you. Okay, I was struggling to get you guys to say that. So you need to have total internal reflection, where the incident light is at a critical angle and it gets refracted back onto itself and keeps going that way. In a sense, you are bending light, and that is done through fiber optics. All right. So you have either fiber optic or gel filled cables. Nowadays, you have transmitting gels, which are actually better than fiber optic cables. Why would I say a gel filled cable is better than a fiber optic cable?
The refractive medium will be constant. It will be.
See, a fiber is a very small, thin fiber of glass. Okay, 7 angstroms, as I remember it. It is a diameter of an RBC, approximately. Okay, so you have thousands of these fine fiber cables going through your cable, and they transmit light. But if you're handling the cable after a case, you take it out, you wrap it around, you make it into a circle, and then put it somewhere, take it out, put it back again. Slowly, one by one, these fibers break. And so each time you lose some fibers, the transmitting capacity of the cable keeps going down. So its life is relatively short, and its maintenance is difficult, and it's expensive. So you now have gel-filled cables, which is just a liquid gel, which has the same properties, but it's not a fiber. And so it transmits better and is longer lasting. Now this gives you the principle of total internal reflection. We have just discussed it. As you know, you keep on. Refraction is the bending of light when it goes from one medium to another. When it goes through one medium to another, it sometimes goes straight like this, and if you have one coming like this, a little thing, and there's one angle called the critical angle. This is a critical angle where when it comes like this, it goes across the direction of the phase which separates the two media. And when it becomes a little more obtuse, then it is totally internally reflected. So this is a total internal reflection cable. This is a fiber optic cable. So you have this cable with total internal reflection. You will have two lenses, one at one corner and the other corner. And so it transmits light. If the cables, if the fibers are aligned in a perfect manner, okay, it can actually transmit image. It's the same principle of flexible endoscopes, for example. Okay, nowadays things are different because there are little cameras at the end of the telescopes, but earlier there were two fiber bundles for transmitting light. I'm talking about an endoscope, gastrointestinal endoscope, not a laparoscope. In an endoscope, there were two fiber bundles which would transmit light. There, the fibers were not aligned in a perfect manner. A random arrangement is good enough, but because it only has to transmit light. But if you want to transmit image, it must be perfectly aligned so that each point on the object that it is seeing will be transmitted to the surgeon's eye. So proper, orderly, aligned fibers transmit image, random fibers transmit light adequately. All right. And so for you, even now, we use gel cables, but there are many centers we still have fiber optic cables as well. So if you have to increase the length or the life of these cables, there must be loose loops. If you have a tight circle, then there's an acute bend and so the fibers break. So you need to have long, large loops so that you maintain the cable better. All right, care in handling is very, very important. You drop it somewhere or you squeeze it in because there is no space and things like that will easily damage the cables. All right, that's very important. Gel filled cables, all right, they're also more stiffer and they're more durable, and that has now this has become the standard. All right, actually we are reaching 8 o'clock. There is a lot more to discuss.
No, sir, time is not a
think-
constant, sir. You can go on, sir.
I
Yes.
really think you guys won't have the attention that can't give the attention that you
No.
have to. Why don't we do it on different
No.
sessions?
Okay, sir. Means,
I think I'm always available. We can do it some other day. Kishan, what do you say?
yes.
Kishan, Nishant, what do you say?
Kishan, sir, are you there, sir?
Yeah, he might have left. Okay, what we'll do is we'll have a compromise. We'll go on for another 15 minutes. Okay, and then we will have another session. Now, we need to understand, we're talking about the basics of the instruments used, creating space, light, and all that. There is a lot more to talk about the lens, the camera, and all that, but we'll switch gears just to make it a little more interesting and learn about how laparoscopy differs from open surgery. All right, that is, it's very different from open surgery. And what are those things that we need to understand? So that once you understand these are the issues, then you're learning the art and the skill becomes a lot more easy. Okay, so Pallavi, go on. Tell me a few things that you can think of where laparoscopy differs from open surgery.
Sir, in laparoscopy, we don't do bigger incisions or anything.
Yeah, that is given. But for the surgeon, in terms of the technique and the learning that he has to do, how does it differ? How does it differ?
A longer learning curve for laparoscopy.
All right. Why is it a longer learning curve? You're right. Steeper. It's called steeper learning curve.
Okay,
Yes.
yeah,
Why is it so?
Handling the instruments and
Not necessarily so. Go on. Anything else?
not
So
very
the
sure.
tactile sensation is
Good.
lost.
Good. You don't have a tactile sensation. That's right.
So because of that, the differentiation between the tissues and that
You're
will be
right.
difficult.
That's correct. That's
So,
correct.
and abnormal tissue, abnormal like vascular tissues will not be palpated. That will with laparoscopic instruments. So
All
chances
right.
of
So tactile sensation is not there. I agree. Yeah. Anything else?
answer. The view is mainly from via a monitor. So
Mhm.
it depends. The clarity and all will be depending on the.
No, actually, clarity will be actually better because your telescope can give you a magnification, which you don't have with naked eye when you operate. All right. All right. Let's go one by one. Anybody else? Pallavi, Rishabh, you want to have a go?
So learning for the vascular control would be difficult.
Yeah, I mean that's a challenge. Yes, I agree. But more than that, you must know even basics. Now, when you do open surgery, you have your both eyes open, and because of that, you have a sense of depth of vision. All right, binocular vision. So you have a sense of depth of vision. Whereas in laparoscopy, it's a lens. It's just one lens, and you have the camera showing the image on the telescope, and so you have a monocular vision. So you don't have the depth of vision. You need the binocular vision to know the depth of tissues. How do you design this? It's very, very simple. I hope I can show this to you. If you have your finger in the front, and if I ask you to touch your tip of the nose, when you're seeing with both eyes like I'm doing now, you go straight and touch your tip of the nose easily because I have a sense of depth of vision. You try the same thing with one eye closed, okay? Then you struggle a little bit and then go and touch. You can still do it, but then struggle and go and touch a little bit. Which means with a monocular vision in a standard camera, there are 3D cameras. I'm not talking about it, but in a standard laparoscopic camera, with the image seen on your television screen, on your monitor, it's a monocular vision with a lack of depth of, field of depth of vision. When that happens, you need to compensate. So that is the first requirement which you have to train yourself in. Then the hand-eye coordination. Okay, when you are operating on an abdomen, for example, you're looking down at the abdomen, you know where your hands are, and the image is directly coming from where your hands are and where the tissues are. But imagine in laparoscopy, you're looking straight at the camera like that, and your hands are down somewhere else there. They're somewhere down there, which means that that degree of coordination is lost as is normal in an open surgery. So you need to develop the skill for hand-eye coordination. Mind you, all these are learned, very easily learned, and a lot of laparoscopy is going on. But these are the issues which you should be aware of. Lack of depth of vision because of monocular vision, hand-eye coordination, and as I told you, limited space. All right. If you are doing an open operation, you have some problem or you don't have good exposure, you extend the incision, shout at your assistant, get one more assistant to wash up, do all this drama, and then somehow you get your job done. But in laparoscopy, you have no such luxury. You can put more ports, and get a little retraction, but whatever you do, the space is limited. Again, I bring your attention to the fact that people are doing very good laparoscopic work in pediatric patients. So even though you have these limitations, you can overcome these limitations with training and with diligence and with commitment. And when I talk about monocular vision, you see, you are talking about a relatively static organ. You're operating with one eye closed, looking at it, and obviously you can compensate for it. And I compare that to a person with one eye. Your generation may not know, but one of our very famous cricket captains in India was Nawab of Pataudi. He had only one eye, vision from one eye. He had lost the vision from the other eye in an accident or something. This guy could face, West Indian fast bowlers of that day. imagine a big missile coming at you with a monocular vision. He could negotiate those fast balls, and he was a very good batsman. So that is the human capacity. So even though you have these limitations of laparoscopy, you can make up for it. And somebody actually mentioned about tactile feedback. Sometimes it becomes extremely important. I mean, having trained only in open surgery and having then graduated to laparoscopic surgery, I can tell you that sometimes I really miss the tactile sensation when doing laparoscopic surgery. There's also the fulcrum effect. Can you think of what the fulcrum effect is? It has to do with the length of the instrument. I'll give you a hint. Tapan.
Sir, means probably it is the based on the lever principle, means that.
You're right. Go on. You're right.
Because fulcrum, if the fulcrum is too close towards us, then little movement from our side will cause massive movement in the
very true. Very good.
Abdomen.
Correct. See what happens you're very correct. Very good. Very good. See what happens is that about a third of the instrument sticks out of the abdomen. 2/3 of the instrument is inside the abdomen when you're doing an operation. So a small movement at your hand exaggerates the movement, because the fulcrum, the pivot against which the movement occurs, that's the fulcrum, is not in the middle. If it's right in the middle of the instrument, the movement of the tip of the instrument will be to the same extent as you move. But because the pivot or the fulcrum is nearer you, then the movement at the tip is exaggerated. So you have to make up for it. On the same count, even if you have a very slight tremor in your hand, it will be highly exaggerated during laparoscopy, which people may not notice during open surgery at all. Okay? And tissue approximation. Now, if you have an open abdomen, you put a stitch in, you do this, you put whatever you want and put tissues together very easily. But that's a little more demanding in laparoscopy. And laparoscopic suturing is an essential skill to have, but is a little more difficult to learn than suturing at open surgery. And of course, specimen extraction is a challenge by itself. You have little holes, 1 centimeter hole, and you have to take out all these things that you have resected, if you have resected. And it has to come through a small hole. There are various ways of getting around it. I will talk about it a little later, but that is a challenge in laparoscopy. So when you have these challenges, as I told you, we have got over these challenges. That's why we are doing a lot of laparoscopic surgery today. So how did we get over this? What were these tricks that we had to do? Let's look at it very, very simple. All right. So to improve the hand-eye coordination, you need to have the same axis. Your eye here, the operating field here, and the monitor. Okay. So if you're standing between the patient's legs, for example, for doing a gallbladder or a hiatus hernia surgery, keep your monitor near the patient's head. Okay. If you're doing something on the spleen, for example, you're standing on the patient's right, you have the organ here, and you can have the monitor there. But look at the arrangement. What is shown here, the telescope is coming here. Your axis is this way, okay, which is at 90 degrees to the telescopic axis, and you will have no hand-eye coordination. Right? And it's very, very difficult to make your instrument go where you want it to go. Very important. So remember, this arrangement is something that will not work, where the telescope is at 90 degrees to the patient's, the surgeon monitor axis. It must be in the same line, aligned in the same line. Okay, eye organ monitor axis must be the same. Okay, the second thing is your hands must be triangulated as far as the telescope is concerned. If the telescope is going like this, your left hand must come there right hand must come here, and it must be a triangle where it meets, and it must meet at 60 to 90 degrees. If you have it very wide apart or very close apart, very close, then you have an issue. And normally this is met if you have at least a hand's breadth between the ports. When you're putting ports, it's very crucial to put the ports depending on what operation you're doing. It's a bit too much to explain all that to you in a basics of laparoscopy class. But remember that the ports must be at least a hand's breadth apart from each other. If you don't have it, A, you will have a problem with hand-eye coordination, and B, you have what is called fighting of instruments. Your assistant is putting something, when he's trying to move something, he will come and clash with your own instrument, and he may actually prevent you from operating. So it's important to have eye organ monitor axis in one line. It's important to have triangulation, and that angle where you meet must be 60 to 90 degrees and not beyond. Beyond that, it should neither be obtuse nor too acute. And to ensure that, you see to it that your ports are about a hand's breadth apart from each other. All right, I think I will stop here. I will stop here. As Tapan said, or somebody said, it is one of the challenges that you have in laparoscopy is bleeding, controlling the bleeding. And we will take it up in the next class. I'll talk to Kishan whenever he's available and schedule another class. Any comments or questions so far, please?
So there's a
there
YouTube
was-
question.
Yeah,
there
go
was a
on.
question on YouTube, sir. What differentiates hypercarbia from hypercapnia? And won't the carbon dioxide continue diffusing into the systemic circulation during the procedure? And how
Yeah.
is that counteracted?
Yeah, hypercapnia and hypercarbia are the same. And what happens is that when you have, carbon dioxide in the abdomen, there is a constant diffusion of carbon dioxide into the circulation. And the anesthetist must make sure that he, if necessary, hyperventilates the patient or increases the ventilatory volume, as it were, the tidal volume, to make sure that the carbon dioxide is washed off. That is why having a capnometer, apart from the pulse oximeter, the oxygen measurement, you always measure the carbon dioxide level in a laparoscopic operation, always. It's done in all operations, but particularly so in laparoscopic operation. The anesthetist makes sure that it never goes beyond 40 or 45. It's a very, very important thing. If it goes beyond 45, you're in trouble. There are a few tricks to reduce it. In case, in spite of the anesthetist's best efforts, the carbon dioxide keeps going up, you have two choices. You can work at a lower pressure. Okay, if you're working at 14 millimeters of mercury in the abdomen, for example, you can reduce it to 12 or 10. And that will give you less space, but with experience, surgeons can manage with less and less space to do the same operation. So reducing the intra-abdominal pressure will reduce the level of the carbon dioxide. The other thing you can do is stop the operation for a while, deflate the abdomen, wait for some time, give the anesthetist a chance to wash off the carbon dioxide, and restart the operation, maybe 2 minutes, maybe 3 minutes later, at a lower intra-abdominal pressure, and you manage it that way.
Okay, sir. Thank you, sir.
Okay, thank you very much. We have come halfway in the class. There are many other things that I would like to discuss, and we will do it, I assure you, in a subsequent scheduled class. We'll call it part 2 of Basics of Laparoscopy.
Yes,
Okay,
sure.
thank you very much, and good night.
It was indeed a very comprehensive clinical class, sir. We could learn a lot from you, and it was very interactive and interesting, sir. You made it very interesting for us. Thank you so much, sir, for the wonderful session. We look forward for more classes from you, sir.
All right. Thank you. Thank you very much.
I
Okay.
thank all the volunteers and all the participants for their active participation. Thank you.
Thank you, and good night.
Good night. Thank you, sir.